Hello, my name is Vašek Tesars. Thank you for listening to Stethoscope, the podcast from the Faculty of Medicine at Masaryk University. And yes, you hear me right, this time in English. Our guest today is Professor Marcy Lobel from Stony Brook University, New York, who has joined the Faculty of Medicine at Masaryk University as a Fulbright Distinguished Scholar. She is an internationally recognized expert in reproductive health and has been focusing on prenatal stress research since the mid-80s. At that time, the public was only beginning to recognize the connection between stress and physical health. Yet there was very little research or scientific knowledge about stress during pregnancy. Professor Lobel was among the first to investigate prenatal stress, helping to develop the foundations of what is now known as the Prenatal Distress Questionnaire, and uncovering early evidence that stress during pregnancy increases the risk of preterm birth and lower birth weight, factors that may in turn raise the risk of adverse developmental outcomes in children, and some of these risks can even manifest later in adulthood. Since the early 90s, when a major study on prenatal stress was first published, its findings have been confirmed and expanded by hundreds of subsequent studies. Professor Lobel, thank you for joining us. I will start with a straightforward question. Is prenatal stress universal and does every woman experience it? Or are there women who go through pregnancy almost stress-free?
Yeah, I think that's a very important and good question. We wouldn't be on the planet right now. Our species would not have survived if every pregnancy that was affected by stress ended up in an adverse birth outcome like preterm birth or low birth weight. So a couple of things. Number one, so some amount of stress is normal in life, right? And one of the other topics that we study is how women cope with stress. And that addresses the question that you asked. So how do some women, hopefully as many as possible, counteract the impact of stress? Do they cope in a way that helps them manage stress, that helps them get support? Social support is a very important, what we call buffer to the impact of stress. And we've done research showing that support from a woman's partner is critical, is important, is probably the most important way to alleviate some of the impact of stress. But we can also get support from our friends, from our other family, and from our healthcare providers as well. That's another important area. So yes, absolutely, what women do in response to stress may help protect them from those effects. And also, I always remind pregnant women that getting proper prenatal care, medical care, is very important. So even if you're experiencing some of these vulnerabilities in your life, it is important to practice those health behaviors I mentioned earlier and to get good prenatal care.
It is well known that a certain amount of stress can actually be beneficial to our health, as it helps us cope with difficult situations in life. If your research focuses primarily on high levels of stress, where is the line between helpful and unhealthy stress when it comes to pregnancy?
A lot of people ask that. Is there, for example, what we would call a cutoff score, right? And we don't suggest that there is a cutoff, because what we see is that stress can be cumulative. And so even for some women, what really matters is how they respond to that stress. Higher stress is worse. You're right about that. And there are some studies that suggest that, like, if you have too low stress, if I can put it that way, if you have no stress in your life, that also can be problematic, because in some studies, those women are not having any interactions with other people. They might be socially isolated, and that's why they report, no, I don't have any problems in my relationships, because they lack those relationships. So those women might also be at high risk.
In one study, I was intrigued by the fact that even good news can be a trigger for stress. But I am a little hesitant to ask about this now, so we don't sound too alarmist, because I assume that in the case of planned pregnancy, news of conception is mostly joyful news.
Well, I also think it's important to remember that what one person finds stressful, another person may not. And so whenever we measure stress, we don't only look at all of the events that are happening to people, but how we use the word in English, how we appraise those events, how we evaluate them or experience them. So I'll give the example of maybe you start a new job. This is whether you're pregnant or not. For some people, that may be wonderful, exciting. They're looking forward to it. Other people might be terrified, right? So it's important when you measure these things to look not only at what we call the stressors or what's happening to people, the events, but how they're experiencing them. And we also look at women's emotional responses to what is occurring. Now, there are all kinds of responses that we have to stress as human beings. We have behavioral responses. So sometimes when you're under stress, we cry, we scream, we curse, we yell, whatever it is, whatever's appropriate or normal for a person. We have cognitive responses to stress, so occasionally your memory can be affected or the way you process information. We have physiological responses to stress, and those are very, very important in pregnancy, as you can imagine, because stress can trigger a cascade of hormones that can actually then trigger earlier birth. That's one of the mechanisms that explains effects. We're talking about high levels of stress, especially in the third trimester. And then what we're interested in are some of the emotional responses to stress, high levels of anxiety that women may be experiencing. So I think that addresses the idea that stress is multifaceted. It has multiple components, and you have to be really careful as a scientist not to neglect any of those components.
So does the danger lies within the intensity of stress or rather in its duration?
Both, and that you're asking great questions, so I want to commend you on that. Most studies suggest that acute stress that is short-lived is not dangerous. It is high chronic stress, the kind of stress I'm talking about where women also are experiencing high levels of anxiety, where their stress hormones may be elevated, and they're experiencing that throughout their pregnancy. Those are the women that are at highest risk. But not if, I can't think of a good example, but something happens to you and it's over within a month. Now, that said, there has been some disagreement among scientists about whether certain periods during pregnancy, pregnancy has what we call 3 trimesters. Each one is about 13 weeks long. And the debate is about whether high levels of stress during first trimester, second trimester, or third trimester are most likely to result in one of these adverse birth outcomes. Some of the research suggests that the third trimester is when women might be most vulnerable. Other research suggests it's the first trimester. And I have always argued in my scientific writing that we have to be aware that anything that happens in the first trimester might have consequences that continue through the pregnancy. So you can't merely look at that as an isolated period. So again, what happens, how women experience it, how they respond to it, how long it lasts, those things all matter.
I recall a situation, my own experience, that before we knew we were expecting our first child, my wife and I went to a wine tasting at a wine cellar. My wife got a little tipsy, a bit drunk, probably partly because of the pregnancy itself, and I spent the rest of her pregnancy panicking about whether it could have a negative effect on the baby. And then a doctor friend of mine calmed me down with these words, "Worry not, even drug addicts have healthy children."
Well, I don't know if I would agree with that last comment, but your description raises a lot of interesting points. One is that I imagine you continued to be concerned about your wife and your baby throughout the pregnancy. And so we're also interested in fathers' stress during pregnancy, how they're affected, how fathers are affected by the mother, right, the pregnant woman that they're having a relationship with, and vice versa, right, how they affect each other. And looking at how father's stress not necessarily affects the birth outcome, but adjustment among couples after birth. Marital adjustment, maybe I shouldn't tell you this, it tends to decline after the birth of a child.
So now even the future fathers listening to us are maybe a bit scared.
You also said something else that raised an important issue. The first trimester is a period of what's called organogenesis. It's when the organs of this embryo are being formed, right? What happens through the rest of the pregnancy, the second and especially the third trimester, now a fetus, no longer an embryo, is growing. So I have always hypothesized in my research that we would see the impact of stress, early stress, on organs, abnormalities, and those kinds of development. What we would see in looking at stress in the second and third trimester, especially third trimester, would be lower birth weight, right? Less growth. Now, I have to say we haven't found great evidence for that, and that's because our sample sizes are much too small in most studies. So what we need to do is collaborate across populations, not only in a given country, but I would wish we could have, a global database. I would love to be able to look, at not just hundreds of women, but millions of women to be able to examine questions like that.
Says Professor Marcy Lobel, our guest today. You are listening to Stethoscope, the podcast from the Faculty of Medicine at Masaryk University. And as you have probably noticed by now, this time it's in English. While the earliest studies on stress in pregnancy were based on the assumption that stress is a generic feeling, Marcy Lobel focused on what is specifically stressful in pregnancy itself. She developed an instrument called the Prenatal Distress Questionnaire, or PDQ, which she later revised over time, and it is now known as the new PDQ. This tool focuses on the particular stressors that create distress for pregnant women. Concerns about the baby's health and delivery, physical symptoms and discomfort, as well as emotional and relational changes. These are some of the most common pregnancy-specific stressors. But what struck me, though, is that changes to one's body are also among them. But then again, I'm just a man.
Well, again, I'll use my own example. In my first pregnancy, I didn't gain that much weight. In my second pregnancy, I was, excuse the language, I was huge. And so that worried me, because very large babies sometimes are an indicator of diabetes, of gestational diabetes. And I was tested for that, and I tested negative. I did not have gestational diabetes. And by the way, women who have gestational diabetes are at risk for having diabetes for the rest of their life, so it can be a trigger. So physical symptoms, changes in body, also changes in relationships are another area that we find women report as stressful for them. Sometimes relationships with their mothers improve. Sometimes family members can be intrusive, right? So that can be a problem. But certainly changes in one's relationship with a partner can be difficult. Women, understandably, throughout pregnancy are concerned about their own health, the health of the baby. And then, I'm sure this comes as no surprise, as birth approaches, you tell me, what are women focusing on? I want you to imagine you're a pregnant woman, it's 39 weeks. What's going to happen next week, probably?
I don't know. Do I have all the things that I need? Will my husband come home on time after going out with friends to celebrate the birth of the baby?
You're worried about the pain and the experience of giving birth. So as birth approaches, as a woman's, we call it her due date, the expected date of delivery, the EDD, as that approaches, women are very stressed about what that experience is going to be like, how painful. Are they going to be able to tolerate the pain? Are they going to be able to have a normal, spontaneous vaginal delivery? That's the terminology for a vaginal delivery. Is there going to be a problem that's going to require a C-section? And then, as you point out, then there are these additional worries. How am I going to take care of the baby? Who's going to take care of the baby? Do I have all the things that I need? Et cetera, et cetera.
The PDQ has been translated into several languages and used in numerous studies around the world. What are the most interesting differences across regions?
Interestingly, we do find that women have more in common across the many countries where the PDQ has been used and where research like this has been conducted. I would say we have more in common than what separates or differentiates us. However, access to high-quality health care is critical in pregnancy. And so women from my country, the United States, that is often a great concern that women in a wonderful country like Czechia might not experience because of your healthcare system, because of the fact that everyone has access to high quality, very high quality, affordable healthcare. Concerns like that can differ. So there are societal issues that are different, as well as attitudes towards women more generally in populations. So women have less status, less power in some countries. And so I think that also affects the way that they view themselves in their pregnancy, the way that women are respected in some cultures.
One of your most recent studies examines stress levels among pregnant women during the COVID-19 pandemic. Thousands of women participated, not only from the US, but also from several European countries. What did you find?
Let's step back for a second and just think about what it was like to be pregnant and give birth during a global pandemic. This was, in many cases, before a vaccine. So there are fears that you might be infected, you, the pregnant woman. There are fears about how the virus could affect the fetus or after birth, could affect a baby. People are dying around you. And now you go to a hospital to give birth. Your husband, mother, sister are not allowed to come. Often they're not even allowed to walk in the hospital. They were sitting out in the parking lot. Right? You walk in, you go into a delivery room, and the people who are going to help you deliver your baby are dressed in full PPE, masks. They look like aliens, right? You can't even see them. You may not be able to communicate with them. That's very frightening. And then after the baby's born, what happens? They get you out of the hospital as soon as possible. They send you home. And now you're at home, you have a newborn baby that you have to figure out how you're going to take care of. Your partner is there, but your parents can't come and visit because it's too risky for them because of the virus. Your sister can't come help. No one can come help you. You're alone with this new baby. So that entire experience was very stressful for pregnant women throughout the world. And when we began looking at the published research, very early research, we were seeing ranges of poor mental health in women, depression, anxiety levels. And so we wanted to see what was causing that. And when we aggregated or combined our data across these countries, we did find differences in levels of anxiety, in levels of stress, in concerns about the birth. But overall, we were able to show that stress in pregnancy was, in all of these countries, a very powerful predictor of mental health problems. So high stress, high anxiety, high stress, higher depression. And one of the interesting factors that contributed, that did differ across countries, was having access to the outdoors. So some countries, Poland, for example, in Poland, they had very strict lockdowns during the pandemic. And that was especially stressful for pregnant women, they told us in our study.
My son was born during the pandemic, but since it was our second child, things were easier in many ways. We knew what to expect, but I can imagine that if my wife had given birth for the first time during the pandemic, it would have been much more stressful for both of us. So I suppose whether a woman is a first-time mother or a more experienced one, it also affects prenatal stress, doesn't it?
Yes, absolutely. So that the term for that is parity. So primipara, or primiparous women, it's not an easy word to say, are women who have not given birth before. And you're right that was also one of the factors. Those women had higher levels of stress in all of the countries that we studied. So you're absolutely right. Your prior experience was important.
You are listening to Stethoscope, the podcast from the Faculty of Medicine at Masaryk University. Our guest today is Professor Marcy Lobel from Stony Brook University, New York, who has joined our Department of Medical Psychology and Ethics as a Fulbright Distinguished Scholar. PDQ serve as the gold standard for measuring the unique anxieties that come with expecting. It is widely used by researchers and clinicians globally to identify women who might need extra support, helping to bridge the gap between routine prenatal care and psychological well-being. By quantifying these nuanced concerns, the tool provides a clear, data-driven window into the maternal experience, making it an essential foundation for the cross-cultural research. I noticed that the PDQ includes questions related to faith, and since the Czech Republic is perhaps the most atheistic country in the world, I have to ask, what role does belief in God play in prenatal stress? What interesting findings have you uncovered?
I'm also very interested in religious belief and also prayer as a way of coping. It's not commonly studied by social scientists, by psychologists in particular, but in the United States, for example, which is not it's much less of a secular country. There are many religious practicing people. We studied the way that women cope with stress through prayer. And this was a study of women who were at high risk. They were at high risk for having a miscarriage or having a low birth weight or preterm baby. They were seen in a special clinic. And what we found, to our surprise, was that women who prayed more became more distressed. It did not alleviate their distress. And I came to understand that because I think that what women were doing when they were praying was really worrying. The English word for that would be rumination. Rumination is thinking about something over and over again. So these women were telling us, they were praying daily, God, please don't let this happen to my baby. Please let my baby be okay. And you can see how that focus could actually elevate their distress. We didn't predict that, but that is what we found. And, I think that's one of the beauties of science is that you have the evidence in front of you, even if it's not what you expected, right? So that was a very important conclusion.
The debates on abortion that have recently captured the attention of the American public can also be traced back to issues of faith. What is the current situation in the United States, and how does the availability or unavailability of legal abortion influence research on prenatal stress?
Now, abortion is not legal at the federal level, but states, because I live in a place where states have some rights to set their own laws. I come from the great state of New York, where abortion is legal. In states where abortion is illegal, which includes states like Alabama, Mississippi, Texas, this overturn of the law has caused the deaths of women because some of them pursue an illegal abortion, which is not safe. Some of them die of complications from their pregnancy because they were not able to terminate legally a pregnancy. There's also been a rise in deaths of newborns. And people wonder, why is that? Well, one reason is that being pregnant in a context where you have no option is highly stressful, is it not? That's something that I study. So these women had very high levels of stress, which may have contributed. We also see earlier births, lower birth weight in states that restrict abortion. But also some of these pregnancies where women are carrying a fetus with abnormalities, those women were not able to terminate those pregnancies. And so they delivered newborns that had a very high rates of death. And one more thing I just want to say about that. many physicians were concerned about prosecution, about being arrested for treating women who were miscarrying, who were experiencing what's called a spontaneous abortion, SAB, or miscarriage. And so there are cases where women died because they could not get a doctor to treat them, to conduct the procedure that is normal when a woman is experiencing a miscarriage. She basically has to have her cervix dilated, and I'm going to use crude terminology, they clean out the uterus, right? What are called the products of conception. And so those women, if they don't have that procedure, they are susceptible to all kinds of infection. They can lose their fertility if their uterus and sometimes ovaries have to be removed. And women themselves have died from hemorrhaging in those cases. There are cases in Texas, for example.
I understand that for the Czech version, you have added a segment of questions related to hope, which is something that our associate professor Alena Slezáčková is interested in. This is probably a bit of philosophical question, maybe. But do you have any expectations of what's the relation between hope and stress might be?
Well, you can be hopeful without believing in a higher spirit, right? And Alena's research also reflects some of the other work that we've done on optimism. So optimists are women who expect positive things to happen to them. They expect that they're going to have a good outcome in their pregnancy. Hope is a very similar factor. These are all indicators of what we would call resilience. Women who are high in hope or optimism are more resilient. You asked earlier, what about stress? Doesn't it affect everyone? And yes, we all experience stress. Some of us are more hopeful or optimistic. And the reason why it matters in some of our studies, and this is of all of the research that I've done in the past, 35 or more years, the study that received the most interest and attention from the media and from the public was a study that showed that optimistic women had better birth outcomes. Why is that? Well, one reason is that people who are optimistic take better care of themselves. And so in a way, it's a self-fulfilling prophecy. If you're optimistic, I'm going to take my prenatal care vitamins. I'm going to get exercise. I'm going to eat healthy. Those women had better birth outcomes. And I don't know if your wife read this book. Maybe you did too when she was pregnant. In English, it's called What to Expect When You're Expecting. And many women, they call it the Bible. It's the Bible for pregnant women, and it talks all about pregnancy. Our research is discussed in that book, the research on optimism. So, imbuing yourself with those kinds of positive attitudes. Now, that said, we don't know if people can create hope in themselves, can create optimism. Some of us may just be that kind of person, and some of us not. So that's still a lingering question in the field of psychology.
I guess that every researcher's ultimate goal, no matter the field of research, is to have a real-world clinical impact. So can you give us an example of that as well?
We have an ongoing project in the United States in our healthcare system where we have developed, we call it a CDS, Clinical Decision Support Tool. And it is a digital tool. What women do is while they're waiting for their appointment, when they come in to visit their doctor or their midwife, they answer questions like the PDQ, like the kinds of questions that are in our survey here in Czechia. And their responses are tabulated very quickly. It's an abbreviated version of the questionnaire that you saw. The answers are tabulated and then immediately sent to the woman's doctor or her nurse or her midwife. Then when she goes into the appointment, her healthcare professional pulls it up on the screen and can see what her risks are based on her psychological state, her health behaviors. Especially, we're also looking at things like whether she's using substances like alcohol, cigarettes, etc., that put her at risk. It also will include some of the medical risk variables. Is she experiencing hypertension, bleeding, other kinds of complications? And it gives a risk score and says, basically, it shows to the healthcare provider what needs to be focused on. And then also provides links to resources. So if a woman comes in and she is responding with very high levels of emotional distress, it says, send her to this person. Here is a link to resources that she can get. If she has financial strain, here are some supports that she can receive. So we are trying to integrate this into healthcare itself. So that is one way that we're using our research to really make a difference in the lives of these women.
To wrap things up and to avoid scaring any pregnant women with this podcast, what's your final piece of advice? What should pregnant women pay attention to, and what shouldn't they worry about?
Okay, so I'm glad you asked that question, because I want to restate something that I said very early in our conversation. We would not have survived as a species if stress always determined a negative outcome in pregnancy. The vast majority of women give birth to healthy, wonderful, lovely, beautiful children. And we're talking about a very small subset of women who may need additional help. And so if you are one of those women, seek that help. I always tell people asking for help is a sign of strength. It is not a sign of weakness. And whether that help comes from your healthcare provider or from a psychologist or from your family, from your partner, help is available. Also, we want to remind all pregnant women that they should take care of themselves, as you pointed out, physically and psychologically. You are number one right now, and the focus should be on you, not taking care of others. Women have a tendency, we all do, I do myself, to be concerned about our parents, our other children, our family members. But right now, the focus is on you. And that includes eating healthy foods, getting enough sleep, taking your prenatal vitamins, going to your appointments, getting some moderate exercise. All of that is important. And I also want to speak to the families of pregnant women, especially the partners of a pregnant woman. My advice is to step up. And step up means offer whatever you can and should to make her life easier, happier, because this is a central time in your life, hopefully a joyous time. And I wish all families to be able to experience the joy that comes with having a new child in their life.
Professor Marci Lobel, expert in the reproductive health, focusing on prenatal stress research, from Stony Brook University, New York, was the guest on this episode of Stethoscope, the Faculty of Medicine at Masaryk University podcast. I hope it was inspiring, not too stressful. I hope my R wasn't too annoying, or my English in general. So thank you for your listening, and next time, in check again, as usual.